Hello and welcome to this special episode of the Akkad and Coco Report. Today we have the pleasure of having Dr. Paul Offit here. Dr. Offit is definitely one of our more academically decorated guests who's come on here. He's very, very well known. He's director of the Vaccine Education Center and professor of Pediatrics in the Division of Infectious Diseases at Children's Hospital Philadelphia. He's the Maurice Hilleman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. He's internationally recognized as an expert in the fields of virology and immunology. And his list of plaudits go on and on. He's also co-inventor of the rotavirus vaccine, Rototech, recommended for universal use in infants. And he's received a number of awards for that work. He's also, should I say a scourge of the anti-vax community, and he's well known in the anti-vax community for his battles with them. Dr. Offit is here in the midst of the COVID pandemic, where he's no doubt isolated in some place in his house in Philadelphia, and so we're very gracious for him to give us some of his time to teach us a little bit about COVID-19, the coronavirus, and what his thoughts are on the response and what we should be doing, what we could be doing different. So Dr. Offit, tell me have you been following this, being a virologist, have you been following this for a while now, ever since, the China report started coming out?
Well, I mean, I think, infectious disease folks have been following this ever since the first novel coronavirus erupted with SARS and then MERS and now this. So sure, I mean, these viruses that have not been seen by anyone in the population, therefore have the capacity to spread across the world and cause a pandemic. Sure. I've been following that.
What, and was there a specific point that made you realize in this particular case that this was different than SARS and MERS?
Yeah, I mean, SARS was the first, and that caused about 8,000 cases, 800 deaths. MERS was next at 2,500 cases, 1,000 deaths. But people that were infected with SARS and MERS were sick. And so it was really much easier to kind of put a moat around them, if you will, quarantine them, and then prevent spread. That's not this virus. I mean, this virus is spread much more easily. There's asymptomatic shedding, there's mildly symptomatic shedding, and so it's hard to know who's infected and who's not. And then you saw what happened in China, where 3,000 or 3,300 people died. And so Wuhan was the epicenter of that outbreak. They were building hospitals. You knew something bad was happening. The question was only going to be how bad.
Oh. And were your thoughts that it was something that would be contained there, or did you kind of think, I think we kind of came on our radar here in that December-January timeframe. January 23rd, I think, is when Wuhan locked down. Is that when you did you think that this would spread in a way kind of across the globe as it has?
Well, we had, I think, a false sense of security after what happened with SARS and MERS. I mean, although, SARS killed 800 people, MERS killed 1,000 people, fewer than 10 people had SARS in this country and none died. Fewer than 10 people had MERS in this country and none died. So I think like others, I think initially had this false sense of security that it can't happen here. But when it started to spread, then things changed.
Yeah, it seemed to be fairly infectious. Right from the get-go. Should infectious disease folks have been more worried? What was that the clue? Given the massive response from China in terms of isolating and quarantining, which they had never done in a mass way with SARS and MERS, was that the clue to us that we needed to start acting then?
Yeah, and in fact, the intelligence agencies testified in front of Congress actually in January that this was going to be a problem. I think we made a number of mistakes that allowed this to come in and didn't allow, and we chose not to respond in a way that we needed to respond, whereas other countries did. I mean, Singapore got on top of this quickly. South Korea got on top of this quickly. Other countries were able to do what we didn't do. Japan also got on top of it quickly, and ultimately China did. China also got on top of it.
What were the major things that we could have done differently early on?
Well, first of all, we should have paid attention to the intelligence community when they did say there was going to be a problem. Secondly, I think we should have really restricted travel very early on from countries where this virus was spreading. We didn't. We waited too long to do that. Once it was in here, then that didn't matter so much once there was community spread. But once we got that heads up, we should have developed testing where we had basically what South Korea did. I mean, South Korea had tested 150,000 people before we tested 500. We made the mistake of putting that all in the hands of the CDC. They had problems with the test. Their negative controls were positive, and so that got delayed. But we shouldn't have put it all in the hands of just that one agency. We should have broadly distributed that, including companies, so we could have gotten more out there. So we could have known sort of where the devil was. We didn't do that either. I think we didn't get ready in terms of providing protective gear, masks, et cetera. We didn't get ready in terms of ventilators that might be needed. So we've just been chasing the tail of this animal since the beginning.
Well, so it is the CDC. It is the CDC's job, and it always has been, I guess, to come up with a one test. Is that, or why is it that they were the only folks that
I don't know. I mean, it's a great question. Why do we put it all in their hands? I mean, we knew that this was a problem. Here, we tested 500 people. We saw that there were people who were now spreading this virus in this country. Still, we were slow to get that testing out.
So because we didn't, I mean, would it have made sense with SARS and MERS to have kind of created a system where we could massively scale things, or?
Well, we had that system. We had it in 2005 when H5N1 bird flu sort of raised its head. Tony Fauci, who has been now in 6 administrations, put in place a pandemic preparedness plan where we could scale up manufacturing for the things that we needed. And co-op manufacturers to make what we needed. And then the Trump administration very early on just dissembled that pandemic preparedness plan because they didn't want to spend the money.
I see. So we just didn't have the ability to scale up as we should have, perhaps. Why is this different? Why is this different than, we frequently hear these comparisons to influenza. Why is it different than influenza?
Well, in a number of ways. I think influenza is worse. I mean, so we're comfortable with influenza. We're comfortable dying from influenza. It's like okay to die from influenza, it seems these days. I mean, think about it, here's influenza this year, at least according to the CDC statistics as of March 7th. 21 to 30 million cases, U.S., 300,000 to 500,000 hospitalizations, U.S., and between 25 and 60,000 deaths from that virus, U.S. So there's no way that this virus, I think, is going to get near to that number of deaths. We're roughly 800 deaths now. I don't think we're going to have 50,000 deaths from this virus in the United States. That's just not going to happen. I'd be surprised if we had 10,000 deaths from this virus. But so you're far more likely to die from influenza because you're far more likely to get influenza. But for whatever reason, this virus has captured our imagination because it does kill people, and it's new, and it's a bat coronavirus, and it's just, it's foreign, as our president would say. So
is it the case also that it comes all at once, that we just don't have scenes, we don't have flu scenes of ERs that go from seeing 10% of folks septic or 20% of folks septic with some pneumonia / influenza complication. And right now we have ERs. I mean, we saw what happened in Italy, and it's happening here now, of course, in New York, where you have these ERs, busy ERs, 60-bed ERs that have gone in 2 weeks from 10% of their patients having some pneumonia to literally 50% of the ER is a dedicated COVID unit, and 50% and they filled up one unit, they filled up a second unit. Now they've built a third unit, and the third unit's filled up. Now they're looking at filling up a fourth unit, all with COVID. So that's partly why it feels so different, right? I mean, what and is that the case of any novel virus that has this predilection for the respiratory tract, I guess, for the pulmonary circuit?
Yeah,
so any novel virus that comes and hits like this is gonna do this because there isn't a built-in amount of immunity to it, and because you suddenly are inundated, the health system's inundated, you suddenly have hospitals that are filling up and getting the capacity.
Right, on top of what we handle with flu every year. I mean, I think there's also sort of a so-called Fecaloral component to this. It does act like that to some extent. Cruise ships, nursing homes, it acts in some ways like norovirus. And so I think when people talk about washing hands, talk about cleaning surfaces, I think that's part. I think fomites is a big part of this as well. I mean, think of New York or Washington State as having this like thin layer of this virus sort of on surfaces, and you have to be careful. So, and I think people got that very early on when they kept talking endlessly about washing your hands. I think that's part of that. Yeah.
I think. So is the precaution And this leads into our question of like what the response should be and how exuberant the response should be. But the fact that the flu, I mean, I guess if the 1918 flu pandemic happened now, if there's some strange strain of the virus that came on board, we would have the same situation, I guess, in terms of the massive number of people that suddenly show up at ERs and kind of threaten to overwhelm our system.
Well, we're better. I mean, in 1918, 1919, we didn't have a flu vaccine. Those didn't come
Right.
around until the 1940s. We also didn't have the kind of intensive care management that we have now. So the last flu pandemic was in 2009, 2010. It swept across the world. It caused about 200,000 people to die. It caused about 12,000 people to die US. That might not even happen with this. And that was a mild pandemic for which we had a vaccine in advance of its coming here. I mean, right now we have about 20,000 deaths in the world. That's a tenth of what was the 2009, 2010 flu pandemic. We had 12,500 deaths here. I'd be surprised if we got to that number with this virus. So, and that was a mild pandemic for which we had a vaccine. But there's some, we're just more comfortable with flu, I think. And I think it sort of reminds me of measles to some extent. When I was a little boy, I had measles, as did all my friends. I was a child of the 50s. We all had measles. Now, I mean, when I had measles, I would have never been admitted to the hospital. I mean, you know, I was sick as we all were sick with measles. Now, if there's a case of measles, kids get admitted to the hospital. So I think when we're less comfortable with viruses, we're much more comfortable. We're much more likely to admit them and get scared.
And what about the fatality rate of this versus the flu? Meaning, it may be true that the flu afflicts a lot more people and therefore causes more deaths, but is it the case that this is more lethal than, and not just 0.1% more lethal than the flu? Is it the case that at different ages, whatever age you look at, it's multiple times more lethal than the flu?
So this virus certainly has a predilection for people who are elderly and have comorbidities like specifically hypertension, type 2 diabetes, and obesity, to a somewhat lesser extent chronic lung and heart disease and immune compromised patients. But look at the 2009-2010 flu pandemic. And that of the 12,000 people that died, 20% were over 65. Most were healthy young people. That's really not true here. It's almost the opposite of that. You're right. If you're over 70 and have comorbidities, you have a 15% mortality rate, which is phenomenally high. But I'm going to predict that as time goes on, we're going to find the mortality rate of this virus was not all that high. And the only way to know that is to do seroepidemiological studies, which was done with that 2009 pandemic. I mean, when that pandemic, when that first hit the United States, the mortality rate was estimated to be 4%. By the time they finally did seroepidemiological studies, it was less than 0.01%. That may be true here too. We have 800 deaths. I think that's real. I think that's a number you can count on. The denominator, the number of cases, because we're testing so haphazardly, there's really no way to know. So if you have 800 cases and you have a 1% mortality rate, then there's 800 deaths and there's a 1% mortality rate, that's 80,000 cases. If it's a 0.1% mortality rate, that's 800,000 cases. If it's 0.01, that's sort of 8 million cases. That's still not a large percentage of the population when you're considering the population of the US is 330 million people.
Don't we have the same issues with the flu? I mean, we don't test every single person with the flu, right? Isn't there also a similar amount of undercounting? Meaning the people that ended up getting tested with the flu they reach some threshold of being symptomatic, which is the same in this particular case, right? You reach some threshold to get symptomatic, and at least the way we're doing it right now in the US. So, I mean, are you saying that the case fatality rate for this is I understand the denominator is unknown, but the denominator is unknown in some cases in some level for the flu as well. Are you saying that the CFR is not significantly different than the flu, or?
I think they're going to be the same. I mean, I think when we did those seroepidemiological studies in 2009, 2010, and really looked at large numbers of people to see whether they really had ever seen this virus before, we realized there was a lot of asymptomatic and mildly symptomatic infection we never identified. And then the case fatality rate was less than 0.01%, even though 12,000 people died, which tells you how many people were infected in this country. Tens of millions were infected in this country.
Dr. Offit, how are these done? Because I'm curious, when you test with serology in the population, I mean, how do you, is there a potential selection bias? How do you get sort of a representative sample of the population? How does that work?
Sure. I mean, there's always a problem with selection bias. But you try and do, usually there's seminal sites located throughout the country that try and do then these studies, and then you project what you think likely is the story for the rest of the country. Obviously, you don't test the whole country.
Right.
Try and do a representative sample, and the question is, how representative is it? Oh, it's always the question.
Right. And the test, I mean, is there currently the test this COVID test, how does it compare to the flu test in terms of its, I mean, it seems that it's not very sensitive, but the flu test may not also be very sensitive. Do we even have an idea, since we don't have a serology to compare it to, or you know, there's no real gold standard? What's your view on the diagnostic dilemmas? Once people are very sick, I think we can it's easier to determine who's infected and who's not. But in the general population, what's your take on this, and how that influences?
Yeah, so I think whenever you do sort of a swab, you know, of nasal mucus, there's always a problem, or the potential problem with sampling error, that you're going to miss something. But you know, it's a PCR test. I mean, so you really are only detecting fragments of viral genome, and that, you know, that can be positive for a long period of time. I mean, I worked with rotavirus for 25 years. You know, you'll shed infectious rotavirus for 5 or 6 days. You'll be PCR positive for 6 months. So in many ways, it does tell you sort of not necessarily what's actively going on, but what's been going on in the past. When people were talking on the cruise ship about not letting people off till they were PCR negative, I felt very badly for those people, because I think that's probably well beyond when they were shedding infectious virus. I mean, the joke that we have in Children's Hospital of Philadelphia is, you know, when kids come in the winter month and have respiratory symptoms, you know, we get this so-called, you know, respiratory panel, which has a variety of viruses. The joke is, you know, $10,000 for the first child who comes in who's not rhinovirus positive.
Is there anything we can hang our hat on right now with this virus in terms of knowing when people are no longer infectious or that sort of thing? What do we know?
There are, and it's not commercially available, but, you know, there are certainly research tools to say when someone is shedding infectious virus, I mean, cultivatable virus. We'll learn about these things in retrospect. I think PCR definitely overcalls infectiousness, would be my guess.
Okay.
So if you're PCR negative, you know, reasonable to go back to work because you're probably not infectious to that point. Okay.
Yes, I agree.
So South Korea, I mean, there are some countries that have, we think, eliminated the disease, if we can believe everyone's numbers. South Korea and China are would you believe that that they were able to eliminate the virus?
Well, I mean, so Bruce Aylward from the United States is in China monitoring things. I mean, he has reported recently in places like Science and Nature that they have gotten on top of this. And so I choose to believe that. I was on a Beijing television show a week or so ago, and there was a variety of Chinese doctors. So maybe they're all lying, but I don't think so. I believe them when they say.
How do you? I mean, we're not able to eliminate the flu. Right. So right. How do you eliminate this hyper-infectious coronavirus?
Well, you know, I think personally you can eliminate the flu. I think even if we did what we did now, we wouldn't eliminate the flu, because it's a respiratory. It's true, that is purely a respiratory virus. This I do think has a fecaloral component, which may make it a little more easy to stop. But we did stop it. I mean, I don't think you can stop the flu. So, for example, I'm going to make the following assumption. I think there are tens of millions of people in China who are still susceptible to this virus, yet aren't getting it. I think that's also true in South Korea. It's also true in Japan. I mean, yet we were able to stop it. That's very encouraging. And it makes me think that there's not just a respiratory, but also a fecaloral component. The other thing would be interesting, I asked this question when I was on that TV show, what's happened to your incidence of influenza in your country? Has doing this, which clearly has stopped the spread of COVID-19, has it also dramatically slowed the incidence of influenza? And they kept talking about how influenza was their friend. So,
what does that mean?
I think it's like they're comfortable with dealing with it. That's okay. This virus, which is, it's okay to die from flu. It's just not okay to die from this virus.
Now, this point that you make about the fecal-oral transmission, we don't hear much about it. At one point, do we have a firm handle on this question? Is it really from epidemiological studies that we determine this, the fecal-oral transmission?
Well, I mean, clearly the virus is shed in feces. I mean, that's been shown. And infectious virus is shed in feces. And you don't have to have diarrhea to shed infectious virus in feces. So I think that's all consistent with the fact that it's true. And now there's studies done looking at how long this virus can survive on surfaces, on a variety of different surfaces. Certainly it can survive for up to 48 hours on surfaces. So I think all that's consistent with the fact that there may be a fecal oral. But the thing that sort of tipped me off to this was with the cruise ships and the nursing homes. That's sort of a classic norovirus story. And we'll see. I think a year or two from now, when the history of this outbreak is written, we'll have a much better idea of what the real story was. I can tell you that for sure the CDC is considering Fecaloral as a route of transmission.
Okay.
So, Dr. Offit, you know, I'm heartened to hear your estimate of what you think the most number of people that we would stand to lose with this virus. Now, of course, there are a bunch of models that are well beyond my scope of analyzing and dissecting that are giving massive numbers, right? I mean, you know, somebody has said there may be as many as 2 million people, or 1 million people that die from this. How have you looked at any of those models? I mean, you're a virologist. I mean, you've come up with vaccines for this stuff. I imagine you have some hard opinion on these models that predict really, you know, hundreds of thousands, if not 1 million deaths. I mean, that's actually a model that the UK, I think the UK is basing it on. The UK switched from whatever they were doing, stratified lockdown, or I don't know what they were doing, herd immunity or something. And they read this Imperial College report. Not that you have to have read that report, but this particular report suggested that the U.S. unmitigated, you know, U.S. doing nothing, we would lose a million people. Is that?
What are they talking about? I really don't get it. I mean, we have 800 deaths in this country. This virus has been circulating in the community for, you know, at least a month or longer, and we have 800 deaths in this population. Now, it's true that everyone's susceptible. Well, not everyone who's susceptible is going to get sick any more than everyone who's susceptible in China or South Korea and Japan, et cetera, got sick. I mean, they're talking like, you know, weaponized smallpox was just sprayed over the entire country all at once. I mean, that's those numbers. I don't get it. I mean, even if this was Italy has whatever, 7,000 deaths or so in a population of 60 million. So that population is about a fifth of ours. So multiply 7,000 times 5,000 times 5, and you're at 35,000. That's still less than the number of flu deaths we have in this country every year. So I don't know where they get that number. I really don't. It's shocking to me, but it obviously scares the hell out of people. And maybe that's the point. The point is to make people so scared that they're afraid to leave their house so that we can really do this, you know, lockdown or sheltering in place. And I do think that's important. Don't get me wrong. I do think we really, until we see that the curve is starting to come down off this logarithmic phase, I do think we need to do this. The problem is I think people think that when they're, okay, now we're sheltering in place, we're locking down. Okay, why hasn't it stopped? The reason it hasn't stopped is because what we're seeing now is what happened 3 weeks ago. Right? I mean, you have an incubation period of probably 5-10 days, then you get sick, then you get sicker, then you get sicker, then you go to the hospital, then you're on the intubator, you're on intubated or you die. That takes weeks. So I think what we're doing now, we will see 3 weeks from now. And I'm going to predict, and so I'll dare to be wrong on this program, that in 3 weeks or so, you will start to see us coming down off this logarithmic phase.
So do you think that what we've done, how has our response been, given that we were late, we didn't have testing, it's been circulating for a while? What do you think? Well, here, let me ask a better question. It's clear that in the United States, there's a regional massive difference, right? Even Philadelphia to New York City, there seems to be a big difference. Clearly, you know, the virus was spreading in a massive way in the community in New York for months, in a way that it has not been spreading in Philadelphia yet. That may happen in Philadelphia, I hope not. But, you know, and many other parts of the country that are even, you know, non-metro areas, there's clearly a big difference. Do you think that the rest of the country must follow the same thing that will happen in New York?
No. I think regions are different, districts are different. I think that what happened in Washington State, I think there was a entrance presumably from China or from the, you know, across the Pacific Ocean that then seeded that area. And then you get things like nursing home outbreaks, where just a lot of virus was being put out there. And the same thing in New York, whether it was, you know, travel from Europe, whatever, New York and Washington are hubs is not surprising. Do I think that that's then going to spread in the same way as we move into the rest of the country? I don't. I think in part because we now know that you know, we need to do hand washing, we need to do social isolation. I think that it's not just respiratory. I do think the rest of the fecal oral component is part of this too. And then I think the virus will have had its day. I do think that I hope I'm right about this. I mean, we know that human coronaviruses, the 4 strains of human coronaviruses that we've known ever since the 60s, we know that that's a winter-spring virus. And we know that respiratory route is part of spread. And the thinking is that as you get higher temperature and higher humidity, that those droplets, that those small droplets start to accrete more water and therefore drop more quickly. That's the thinking. Greece is currently not suffering this disease much, as distinct from neighbors to their north. So if it's true that climate matters, if it's true that seasons matter, then I'm optimistic that we'll start to see this fading. I mean, you know, we had a measles epidemic, for example, in 1991 in Philadelphia, where we had this is, you know, 1991, you're 30 years into the availability of a measles vaccine, but there were two fundamentalist churches that chose not to vaccinate their children. They had big child care centers and stuff and big schools. So in that city, in our city, in a 3-month period in 1991, we had 1,400 cases of measles and 9 deaths from measles. I mean, one city, one season. And as we were running around like chickens with our heads cut off. We were vaccinating down to 6 months of age. We were setting up clinics. You know, we were all really upset about this. And Bob Levinson, who was the head of the Department of Health in Philadelphia at the time, said, when the weather gets warmer, it's going to stop. And that's exactly what happened. Come early May, actually, it just stopped. Not sure why these things are true, but that was certainly true for measles. And maybe it's the same reason as what may go on here. Well, you know, you don't know, because you know about human coronaviruses. This is not a human coronavirus. It's a bat coronavirus. And so it hasn't been in the population very long. So you don't really know what the story is. Although flu is a bird virus, that virus has been much better adapted to the human population. So they're different viruses.
So what do you think of our response so far? Should we have done something in terms of a mitigation? What do you think we're doing?
Well, the administration denied this initially. It's not a big deal. We're getting on top of it. It's going to go away soon. I mean, because, you know, they just denied it. They hoped that if they put their hands over their eyes, it would all go away. It didn't work that way. I honestly think the administration didn't start to pay attention to this till the market went down. When the market started to crashing, then they realized this was a big deal and something needed to be done. And then they went almost in the other direction. Yet no more crowds greater than 10, you know, which was not the CDC's directive, which was 50. But so they sort of got much more interested in sheltering in place, et cetera. I think what you need that we don't have is a federal policy. I mean, you need to know what the plan is. So right now, they just sort of turn it over to the states and ask the governors to figure it out on their own. So we're kind of lurching in the dark. I mean, there's two pandemics, if you will, that are occurring now. One is the one that's caused by the virus, that's going to cause people to suffer and be hospitalized and die. And the other is the pandemic of joblessness that is about to hit. I mean, if the 20% joblessness correction or prediction is correct, that's 35 million Americans that are going to lose their jobs. And with joblessness comes homelessness, and with homelessness comes crime and violence and domestic abuse and child abuse and depression and suicide and all of the fallout of major economic downturns, especially among the poor. I think that's really where you're going to see it. And dealing with, how do you deal with that? So right now you're trying to balance these two things. There's no clean solution. There's no perfect solution. But I do think that as we start to come down off this curve, we need to have criteria for when we know hospitals aren't being overwhelmed. We know we've gotten on top of this, when we know that we can go back to school, that we can go back to work at some level, because that's going to have to happen. I was just on a conference call with the board of trustees at the Franklin Institute, and they really care about their workers, but these workers are going to get laid off. That's the way this plays out.
So, do you think that'll be driven by testing and testing negative, or is that kind of the solution moving forward?
No, I think it's going to be the hospitals that really give us the most information, because that's the biggest fear, that you overwhelm your healthcare system, which will not only affect those who have this virus, but also those who need hospitals. So I think that's what we need. We need sort of a coordinated understanding of in which situations, districts, regions, states, hospitals are or not being overwhelmed, so people can now start to crawl out of their homes and go back to work again. That has to happen. I mean, you watch these gut-wrenching decisions about people laying off their workers who have been so dedicated to them. It's just hard to watch, but it is. And I can tell you the true $2 trillion package will not be the thing that solves all this. Because first of all, people aren't going to spend money if they're afraid to walk out of their house, and they're not going to go to a movie theater if the theater is closed. So we need to figure out a way to get back in the game here.
So it really... It really is. It really is remarkable to watch. I run a private practice, and I mean, I'm on the top floor of a 10-story building, and the entire building shut down just on Sunday, or we got an email Friday or Saturday. So I'm the only one open at the moment for urgent visits, and we're doing telemedicine or whatnot. And as I was walking the door on Monday, the woman at the door stopped me. She's kind of not the guard, but she's the person who lets people in and screens people, or some brief screening and a sign-in sheet or something like that. And I thought she was gonna stop me and tell me to stay away from her because I was in scrubs. But she stopped me to thank me and said, "Thank you so much for staying open," because I was laid off as of Friday, and then I got another email saying, "Oh, Dr. Cook is still open, so we still need somebody there." But it's so amazing to me that it happens that quickly. That quickly, the building shuts, and suddenly everyone is laid off. The cleaning crew that came to my office, they've laid off 90% of their staff. The folks that do maintenance in the building, all but one person is laid off after this week. It's amazing. And with that goes health insurance. We have this idiotic thing where we tie health insurance to employment. And so it's just, you can kind of see the train wreck. I mean, you see two train wrecks happening, exactly like you said. You see the train wreck happening, at least right now, and to our poor colleagues in New York, who are just getting inundated and flooded with patients and whatnot. And then you have this other train wreck happening, at the same time. And I am shocked and surprised at how quickly that's happening. And I think a lot of so you're exactly right. I mean, I think that's going to be, the cost of that isn't just in dollars, isn't just in the stock market. The cost of that, there's real health implications to putting 20-30% of the country out of work.
Okay.
Sorry, Michelle.
Yeah, no. So Dr. Offit, I'm very pleased to hear your point of view. I mean, I think Anish and I tend to share it, but it's more by instinct. Whereas you're an expert in the field, but what's surprising is that it seems that among academics, and you're in the minority, it seems to be that what we hear from people who are in epidemiology, and I'm not sure, maybe it's a false impression, but it seems that your more balanced response seems to be a minority view. And how do you explain that? Or I'll give you an example. Dr. Fauci yesterday, or maybe the day before, was asked on a press conference whether he thought his job was to only think about defeating the virus versus have a more sort of global view. And he said, no, my job is to just defeat the virus, and I'll leave it to the president to make the decision about what to do sort of globally. And what are your thoughts about why you're in the minority, and why that view is not more prevalent? Because public health is public health in general, right? I mean, it should be taking into account just about everything.
Well, I do think that narrative is changing. I mean, David Katz had an op-ed piece in the New York Times a couple of days ago saying just exactly that. I mean, is the cure worse than the disease? And you're starting to hear at least that other side of it, that, this massive unemployment that we're about to have happen, that's not going to be alleviated by a couple of checks, from the government, is a big public health issue. People are talking about that now. People finally are talking about establishing criteria for what it means to say that we can now consider going back to work, and in what settings and how to do that. So I do think that conversation is definitely happening. So although I think I was a minority speaker initially, I think that's happening. Okay,
well, let's hope so. But then a related question is, we mentioned these models that project, millions of death, and you see that again coming from academia, and at UCSF apparently a couple of weeks ago there was a conference that sort of started circulating these prognosis, these really grim prognoses. Is this something new that to rely on these mathematical models? Is this something that's new, or has it always been the case that people have, epidemiologists have tried to predict whenever there's a new virus on board, to predict what's going to happen?
Yeah, well, again, I'm not an epidemiologist, I'm a virologist, but I
Right.
think I think that there's nothing new about that. I think what would be interesting is to see the people who really stand to lose. You know, like banks, you know, just they're spending millions of dollars trying to model all this. You know, I hope they share that information with the government, because I tend to trust people who have the most money to lose usually come up with the best models. So we'll see.
All right.
Do you get a sense in your community, in the virology community, are most folks thinking like you're thinking? I mean, again, your comments are greatly colored or greatly informed, I should say, by the history. I mean, you obviously have you have a Rolodex in your mind of the H1N1 flu, what it was, and the flu season, and how many people die with that. The rotavirus, how many people die with that, et cetera. So you're informed by history, whereas pure technocrats, if you will, who are coming to this, they basically have models that make some simple assumptions in terms of, well, this is the case fatality rate, this is the age, this is the R naught, and this is how many people will get it, and therefore, and that's, you can see how they come up with these numbers. Is the virology community more in line with what your take is, which is a little more of a balanced take in terms of?
Not near as I can tell. Here's what surprised me in this. Yeah. I think viruses are scary usually for three reasons. One, because they affect children. So poliovirus, it was a feared scourge. My mother never let us go to any public swimming pool when I was young in the 50s because she was afraid I was going to get polio. So that's number one reason people are scared. The second is that you're very likely to die. So rabies. If you get rabies and you develop symptoms, you're dead. So that's virtually 100% fatality rate. The third reason is that there's something unique about the symptomatology that's particularly grim. Smallpox, for example, is disfiguring. It leaves people, for the 2 out of 3 that actually survive that infection, it often leaves people blind, leaves permanent scarring. This is none of those. I mean, this is just is a respiratory virus. It acts in many ways like a respiratory virus. It probably may well have a mortality rate that's greater than flu. We'll see, but I'm not sure, and maybe you can answer this better than me. Is it the 24-hour news cycle? What is it that makes this particularly scary? Because I can tell you, I would be shocked if this virus does what flu did in 2009, 2010 during that pandemic. And that was a pandemic we had a vaccine for. And also that was a pandemic that primarily killed healthy young people, as distinct from this, which kills people like my age. I mean, I'm the one who should be worrying on this call.
Well, the question is to you. I'm asking you what your virologist friends are saying. Why are they saying? Why do they find you out of step? Or what is concerning them so much? So that you're saying they're succumbing to the lay press, to the panic that seems to be.
No, I don't think that's necessarily true. I mean, I talked to a woman today who also was saying, first of all, our hospital could not be at lower capacity right now, and we're shutting down wards. It's nobody's coming to the hospital. Right. The hospital next to us, the hospital at the University of Pennsylvania, also doesn't seem to be suffering terribly. But New York is, and I think what happens is the media plays that up. So it's like what happened, as Andrew Cuomo says, we are your future. Where what's happening here is going to happen, and so he scares the hell out of people. And I think he's wrong. Actually, we'll see how it plays out. We have 800 deaths. Maybe we'll get a few thousand deaths when this is all said and done. I just would be shocked if we went to 12,000, which was a mild flu pandemic 10 years ago.
Right. I think, the one thing that I think we're not used to seeing, and again, I'm not as old as Michelle is. but the one thing that I haven't seen in my whatever 10, 15, 20 years doing medicine at this point is this kind of bolus of folks arriving at hospitals that seem to rapidly push you to the limits. That's something we're just not used to seeing. I mean, we're used to surges. We're used to bad flu seasons, and things are bad, and we're putting people in the PACU. But I've never seen three separate new units built, and all of them get filled up with patients being intubated. I think it's that kind of.
But that's only in pockets, right? I mean, that's only in hotspots.
Oh yeah, it's in pockets. Right. But the problem was because we weren't testing, right? I mean, when I kind of shut things down, there were a bunch of cases reported in Montgomery County. I have a bunch of kids in the school district. My oldest kid, has had a liver transplant, is on immunosuppression. And so when I saw a bunch of cases show up in Montgomery County, I got really nervous that I was like, oh my God, we may have thousands of cases in the community and we just don't know it because we're not testing. I wasn't sure if we were New York, what ended up being New York or not. And now it turns out in the last 10, 14 days, clearly it seems that for multiple reasons, I have a primary care doc who works with me, and we field calls all the time for fevers and stuff. And I haven't seen an uptick in that. I have a drive-through testing center that's right next to me. And that's basically, every time I walk by, it's not that busy. So it clearly seems that the prevalence of disease in our area in Philadelphia is much, much different than what's going on in New York City. But 2 weeks ago, when Italy hit and you start to see cases being reported around the community, you just don't know whether you're the tip of the iceberg, or
See,
not.
Italy's also, I mean, everybody keeps pointing to Italy. Italy,
Yeah.
First of all, 25% roughly of their population is over 65, as compared to 16% here. So they have an older population. It tends to be more northern Italy than southern Italy, more the area around Milan and Rome, which is a rural area. I think there wasn't the intensive care, healthcare available in that area as compared to here. I think there were people that died in that country that wouldn't have died here. So I'm not sure that when we point to Italy and deaths in Italy, that's necessarily
right.
What would happen here?
Yeah, though New York is clearly, I mean, they've got a bajillion hospitals, right? And they have a lot of capacity. And I mean, again, it's somewhat, you somewhat have the number of hospitals that you have, certainly in the United States, somewhat relates to the population that you have. And we certainly I think we have more capacity, especially in our metro areas, than most other parts of the world, even though that may be hard to figure out anyway, that may be hard to figure out in some type of peer-reviewed nature, but I think we have a lot more capacity in other places too. But despite that, it seems that the exponential growth of the virus, once you have a critical mass, can overwhelm the hospital resources that you have built to deal with what you have. So, I mean, I don't think, in talking to the folks on the ground in New York City, I think they're going to be pushed to the limit, and I'm pretty sure that they're going to have to end up using, the Army Corps of Engineers is building, 2,000 extra beds in the Javits Center. Each hospital is doubling their capacity to try to meet the surge. That's just something that hasn't happened, and certainly in what we know or what we understand. So
see, what I'd like to see is to see in New York a side-by-side comparison as we went from 1 week to the next of the number of people in New York who died of this virus and the number of people in New York who died of influenza. Just side by side, I'd like to see that. I mean, because right now, maybe, what is it, 170 or so people have died in New York City or New York from maybe 200 people. It's only 800 total deaths in the US. So maybe a couple hundred deaths. I know they're the epicenter. So, something like that, in that range. I'd just like to see the number of deaths from flu. I'd like to see that lined up next to the number of people in the ICUs from flu, number of people who suffer from flu. I'd just like to see those numbers in comparison, just to put this in some context.
Yeah, I think you're going to find that number to be, I think you're going to find that number to be fairly impressive. I think there are 941 deaths in the U.S. 285 of them are in New York, and they're dealing with, I think, 4,500 to 6,000 new cases a day of the disease. So,
right. I mean, it seems to me that there are local factors that maybe completely, we don't have a good handle on.
Yeah.
But why is it New York? Why is it northern Italy? We've been talking about these super spreaders in North Korea and whatnot. Are these common with is there such a thing as a super spreader of the flu, or is it particular to this virus?
There was certainly a super spreader associated with SARS. I mean, that was the Toronto experience. So
Right.
I mean, I think that it's possible, certainly with coronavirus, to have a super spreader, even with relatively mild symptoms.
Right. So would that sort of explain local differences, or could explain local differences that kindles
and
enough?
Again,
right.
Fomites, I think, are a big part of this too.
Right.
Yeah.
Right.
Well,
it's very, really fascinating. The side-by-side comparison and this panic. I mean, we're all glued now to the worldometer. Right, every day, every morning, twice, 3 times a day, look at the statistics and they see the numbers, and each time they go up. We have no experience of that with the flu, and as you said, I mean, if we did that every season with the flu and keep tracking, we'd see the exact curve, right? And it goes up, and it'll probably come down. do you make anything of the fact that, China went up and down, South Korea went up and down, reasonably similar sort of time frame, fairly radically different approaches. I'm not saying that we shouldn't do anything, but is there something to be said about, that essentially these things, have a natural history? And I mean, it's too early to tell. We don't have serology and so forth. But I mean, if Iran starts to come down, I mean, I saw their death, their numbers are still a little bit scattered. But if Iran starts to come down, then you think, well, maybe there's just there's just a natural history, and these things eventually go away.
Yeah, no, I think a year or two from now we'll know that. We'll know the history of this,
Right.
and we'll know who the heroes were, and we'll know who the villains were. We just don't quite know who those people are yet.
Yeah, no, I think things will certainly get a lot clearer as time goes on. Because you're right, we don't do this. We don't track anything else like the way we're tracking this. So,
Right.
All right.
But extremely important to keep the whole picture in mind and not just focus on
and
these
the good news is
statistics.
And the good news is that Dr. Fauci and I imagine Mr. Trump is taking his cue from Dr. Fauci and Dr. Birx, in terms of looking at this not as a lid that you leave on the nation for some endless period of time, but regionally to kind of look at, and based on data, this is what Dr. Fauci was saying yesterday in the press conference, based on data, try to look and see if the transmission is low, if the prevalence is low, then allow people to start kind of creeping out of their homes. You're saying, of course, the other canary in the coal mine, if you will, is also the hospitals. And if clearly the hospitals are not getting overwhelmed, another obviously maybe more important, phenotypic sign that, hey, this is okay, and now we can go to restaurants again. That's a good question. Dr. Birx was asked this, and her answer was not very reassuring. Will we ever be able to?
What did she say?
Well, the question she was asked was, essentially, I'm paraphrasing. The question she was asked was, will we be able to, will things go back to normal? Will we be able to go to a football game again? And her answer wasn't very reassuring. Her answer was, well, I hope so.
I mean, eventually this will stop. I mean, it has to stop. Because herd immunity, I mean, you'd like to induce herd immunity with a vaccine. We don't have a vaccine. So we're inducing herd immunity to some extent with circulation of wild type virus. I mean, which is why you could argue we probably should have never had to close schools. I mean, that was never a CDC directive. I mean, people just did that on their own. And Singapore certainly stopped transmission without ever closing schools. So it's possible. But I mean, this will end. It will. It will end, and there will be an NFL season, and the Eagles are much better positioned this year to do well. So I'm optimistic.
On that note, can you give us your perspective on vaccine development? Because I've heard you speak to that, and I think what you say is important for people to hear about.
Yeah, so I mean, here's the good news about a vaccine. You know from human challenge studies actually decades ago with coronaviruses that there's so-called homotypic immunity, meaning that if you are infected with one strain of coronavirus, human coronavirus, and then you're challenged with that strain a year or more later, that you're protected. That's good. If natural infection can protect against disease associated with reinfection, then you can make a vaccine. Mm-hmm. That's the first good sign. The second thing is you have a pretty good idea that what you need to do is make an antibody response to the spike glycoprotein, because that's the protein that attaches to cells. If you can prevent cell attachment, you're very likely to be able to prevent infection. I mean, it's true for hepatitis B, it's true for human papillomavirus, it's that surface protein. So that's good. You also have things in place like mRNA technology, messenger RNA technology, or DNA technology, or just recombinant DNA technology that lets you make a purified protein to do that. And you can adjuvant that protein to do that. So all that's good. You would like to think that we will do animal model testing, that will go through, thousands of people with phase 1 and phase 2 testing before we ever release that vaccine. And maybe I'm a bad sport because it took us 26 years to make a rotavirus vaccine, but, just the notion that we could make a vaccine in 12 to 18 months to me seems outrageous, but, we'll see. I do think that I would offer this one warning, though. Make sure this vaccine is safe before you put it out there. Make sure there's no such thing as immune enhancement, for example, that you actually, when you're exposed to wild-type virus, do worse, because most of the people who are going to get this vaccine were not going to die from the virus. So, they're going to be healthy young people. Make sure that's true. I think We owe it to that. And when people are panicked, and they're panicked, they're willing to sort of cut corners with not just with vaccines, but with antivirals or drugs like hydroxychloroquine or something. So be careful is all I'm saying.
Is it the science of vaccine development that took 26 years, or was it regulatory barriers, or what was?
Well, we did extensive animal model testing, do proof of concept studies, meaning, we had an animal model where we could make the animal sick with rotavirus. And so then it's the virus is a little more complicated than this one. There are two surface proteins that evoke neutralizing antibodies. Did you need both? Did you just need one? So you had to sort of do that. And, it's a segmented genome, so you can make these reassortant viruses, which was the approach we used. And then when we had done that, then we went to phase 1, phase 2, but the phase 3 trial, the single phase 3 clinical trial, was a prospective placebo-controlled 70,000 person, 11 country, 4-year, $350 million trial to prove that vaccine was safe and effective before you then put it into babies, which you have to do. I mean, if you're going to give the vaccines to healthy people, you have to hold them to a high standard of safety. It's different with treatment. I think people are willing to accept side effects with treatment far more than because you're already sick.
Mm-hmm. Have there been any vaccines that have had horrendously bad outcomes? Because
yes,
okay.
Let's start from the beginning. I mean, the RSV, respiratory syncytial virus vaccine in the 1960s, was a whole killed virus. That ended up sort of disrupting the fusion protein of that virus, so that when then children were naturally infected with RSV, they did worse. That mistake was repeated for the measles vaccine in 1963. Again, a whole killed virus that disrupted the fusion protein, that then when you were infected with natural measles, you actually were more likely to get pneumonia. Dengue is another example. There's the dengue vaccine, Dengvaxia by Sanofi. If you got that vaccine and you'd never been infected with dengue before, and then you were exposed to wild-type virus, you were more likely to be seriously ill with dengue hemorrhagic shock syndrome than if you never got that vaccine, because of something called antibody-facilitated enhancement. So yeah, be humble. There's a lot of surprises out there, things that you haven't thought about. The history of breakthroughs, medical breakthroughs in this world is built on tragedies. Or I think there was Michael Harris, a historian, said, the history of drug regulation is built on tombstones, and that's true.
Oh boy. Well, so then is an antiviral therapy something that would be more promising in terms of time frame, in terms of getting something that works?
Sure. Well, you have them. I mean, you have remdesivir, which is a protease inhibitor. This is a virus that has a protease. You have flavipiravir, which is an RNA-dependent RNA polymerase inhibitor. This is an RNA virus. So I think there's reasons biologically to think those would work. The hydroxychloroquine azithromycin story doesn't make as much sense to me, and I certainly hope people test it, because I know doctors are just giving it now, thinking this is going to be a wonder drug. But when people are sick, you think you can't hurt them. You can hurt people who are sick. I mean, people are sick, one of three things can happen. They can do better, they can do worse, they can stay the same. Don't take people who are going to do better and stay the same and make them worse, which you can do.
Is the specific issue with hydroxychloroquine and azithromycin, is it just implausible to you as a virologist that it could work? I mean, the French paper said the viral. I know. Look, lots of caveats. Bad paper, etc.
Terrible paper.
Not double blind. Not RCT.
But been published.
Is there any in vitro evidence to suggest that, or you think it's just implausible based on what you know about HCQ and azithro and how it impacts viral shedding or etc.?
Well, I think the thinking is that the hydroxychloroquine will change the sort of pH of cells, specifically macrophages, and that will make for a more hostile environment for viruses to grow. But I just would be surprised if this were that paper should never have been published. It was a terrible paper, and I just think it's misleading.
What about the in vitro? Is there any good in vitro evidence that works? So that even
I don't know those data.
No, you don't know. Okay, all right. The antivirals that we're talking about, remdesivir, et cetera. Is this the kind of thing that similar to HIV, for instance, right? Well, HIV is probably not a good example because that was a very tangled web in terms of how we came up with a solution. But do you think that there's going to be a single agent, and if it does work, it should be obvious very quickly, meaning there are trials that you need, vaccine trials, because you're giving healthy people, you need to do 70,000, follow them for 4 years. I mean, this is what we do in cardiology all the time with statin trials, right? But in this particular case, knowing the mechanism, is this something that we should see very quickly with 30 people?
So do I think that remdesivir or favipiravir will work? Yes,
Or
I think they'll
okay.
work, and I think we'll know fairly quickly. The vaccine story is I don't know how exactly you do an efficacy trial. It's easy for us to do efficacy trials on rotavirus because everyone gets infected with rotavirus. I mean, here, even if the mortality rate is 0.1%, you're still talking about a very small percentage of the population in the U.S. that's infected with this virus. So I think you're probably going to just have to settle for immunogenicity studies, which is what we do with meningococcus, where 300 people a year get serogroup B meningococcal disease, yet you get a licensed product without doing an efficacy trial. See, Ebola was different. I mean, Ebola, that was a major outbreak in West Africa. And so as they rolled out that vaccine, you could see who got it and who didn't get it, and you could tell whether it was effective. That's not that kind of level of infection here, at least not now.
Okay. But certainly, I doubt that the vaccine was part of the models that have dire. I mean, the medications, the antivirals, are not included in the very dire models that are being rolled out, because it's clearly these things really can change the course of the epidemic quite quickly.
I don't know but these are the same people that produced the movie like 28 weeks later. I mean, it's grim.
All right, Dr. Offit, thank you so much for giving us an hour of your time. Really, really great. I learned a ton. I'm sure the audience will.
That was fun. Thanks very much.
Thank
Take
you,
care, guys. All right, stay safe.
Bye. Yep, you too.